In emergency toxicology, specific reversal agents have the power to halt irreversible organ damage in minutes, but they don't replace the bedrock of clinical resuscitation. Not every poisoning has an antidote. Administering an antidote prematurely, without first securing the patient's physiological presentation, can trigger catastrophic and sometimes fatal adverse effects. This flowchart maps the clinical algorithm for treating a poisoned patient. The first step following a suspected poisoning is the ABCDE assessment. Securing the airway, breathing, and circulation takes absolute precedence. Chemical reversal is irrelevant if the patient is hemodynamically unstable. Once the toxin is identified, the protocol splits. For the majority of toxic exposures, no specific antidote exists, routing the clinical team straight into aggressive supportive care. Even when an antidote is available, it's administered concurrently with supportive care, feeding directly into continuous monitoring. This sequence establishes the golden rule of emergency toxicology: stabilize first, antidote second, monitor continuously. The efficacy of a reversal agent depends entirely on the physiological stability established during initial resuscitation. Clinical antidotes utilize six biochemical pathways, starting with receptor antagonism. In opioid toxicity, opioid agonists bind to new receptors, suppressing respiration. Naloxone, possessing a higher binding affinity, physically outcompetes the toxin, forcing it off. It occupies the space without activating it, creating a temporary pharmacological blockade. Flumazenil operates on a similar principle, acting as a receptor antagonist for benzodiazepine poisoning. Clinical guidelines reserve flumazenil for selected patients only. In chronic benzodiazepine users, stripping the receptors so abruptly can induce intractable, life-threatening seizures. Receptor antagonists compete for physiological switches without clearing the toxin from the bloodstream, requiring precise clinical judgment to prevent abrupt, life-threatening withdrawal. Enzymatic antidotes alter how the body processes toxins through enzyme inhibition and reactivation. Fomepizole treats methanol poisoning. Normally, alcohol dehydrogenase breaks methanol down into toxic metabolites. Fomepizole blocks this enzyme, capping the binding sites to halt the metabolic process, allowing unprocessed methanol to be safely excreted. Organophosphate poisoning requires the opposite approach, utilizing atropine alongside a reactivating agent called pyridoxime. Organophosphates paralyze the nervous system by binding to acetylcholinesterase. Pyridoxime forcefully decouples the toxin, restoring the enzyme's normal function through enzyme reactivation. These powerful enzymatic antidotes neutralize the toxin's pathway of destruction by directly manipulating the body's metabolic processing speed. The phytal mechanisms capture toxins or repair damage. In toxin binding, digoxin immune Fab deploys antibody fragments that snap onto digoxin molecules, creating inert clusters for excretion. In chewation, deferrexamine completely envelops a toxic iron ion, forming a protective chemical cage for safe removal. Metabolic replenishment involves restoring depleted cellular reserves. N-acetylcysteine prevents liver failure in acetaminophen overdoses by replenishing the hepatic glutathione needed to safely process the drug. Other pairings follow exact chemical logic. Protamine sulfate binds to heparin, vitamin K replenishes clotting factors, and hydroxycobalamin directly binds cyanide. Whether enveloping heavy metals or restoring hepatic reserves, these interventions demand perfectly mapped chemical administration to prevent irreversible end organ failure. Administering these agents aggressively alters biochemistry, demanding clinical vigilance. Nurses rely on an algorithmic checklist mapped to the mnemonic antidote, assessing ABCDE, naming the poison, timely treatment, and identifying the antidote. Execution requires double-checking the dose, observing response, treating adverse effects, and evaluating continuously. Before pushing any high-risk reversal agent, the nurse must verify drug compatibility, confirm exact dose calculations, and check patient allergies. Bedside resuscitation equipment must be immediately available before the drug enters the IV. Algorithmic preparation is the clinical firewall. An antidote administered without strict protocol adherence transforms a life-saving agent into a secondary hazard. The need for aggressive supportive care continues long after an antidote is administered. This graph illustrates the half-life trap. The red curve represents an opioid's long biological half-life. The blue spike is naloxone. It wakes the patient, but its half-life is much shorter. As it wears off, latent opioids rebind, plunging the patient back into respiratory depression. known as recurrent toxicity. This physiological reality mandates continuous ECG, respiratory, and vital sign monitoring for hours after the initial clinical response. In high acuity poisoning, the success of the clinical intervention is ultimately measured at the final node of the flowchart: continuous monitoring. An antidote success relies on rapid physiological stabilization, accurate pharmacological mapping, and relentless nursing vigilance. Respect the pharmacology, but rely on the protocol.